Our board host today is Bill Frank, who has the privilege of asking our speaker the first question. You will find, again, on the tables written forms for writing questions. I encourage you to be thinking of questions during our speaker's presentation today, and at the conclusion of his presentation, we'll be taking the written questions alternating with questions from the floor, and I'll say a word more about that when the time comes. Few aspects of our American life have changed as dramatically in the last decade or two than our health care service industry. Our nation has faced a variety of new medical issues in recent years, controversies surrounding organ transplants and the prolongation of life, the AIDS epidemic, competition among hospitals unheard of a few years ago, rising costs of health insurance for patients and malpractice insurance for doctors. There's a long list of controversial topics, many of them, perhaps most of them, in one way or another, involving economic questions, financial questions. And one of the most pressing issues in Oregon, as it is in several states, is the question of providing trauma care, care for victims of accidents or violent assaults. Our speaker today is well qualified to bring us up to date on the status of this issue in Oregon. Dr. William Long is director of the trauma program at Emanuel Hospital, which treats more trauma patients than any other hospital in Oregon. Dr. Long is a native of Baltimore and received his medical degree from the University of Maryland. He was trained as a cardiothoracic surgeon, and he has been a leader nationally for several years in developments relating to trauma care. He came to Portland from San Diego, where he was clinical director of the trauma center at UC San Diego Medical Center, and he has been at Emanuel Hospital since he came to Portland in 1983. His topic today, saving lives and money. Will a regional trauma system help? Please welcome Dr. William Long.
Mr. Hinkle, Mr. Frank, members and guests of the City Club, thank you very much for the invitation to come and to address you about this timely topic. And I am pleased to be representative of the Area Trauma Advisory Board, which has worked so hard in the past year and a half to put this plan together to be approved by the Oregon State Health Division and the State Trauma Advisory Board, and will now be soon hopefully be implemented sometime in this early or mid-fall. I thought what I would do to give you some background of the need for trauma systems and why we are considering it here in the Portland area. I will give you some background on what is happening nationally, and then what is happening locally, and then what we're going to do about it. Some of the statistics some of you might already be aware of. For the ages of 5 through 34, trauma accounts for more deaths than all other causes combined. For American teenagers and young adults, the death rate from trauma is 50% higher than any other industrialized country. For every trauma death, there are at least 2 permanently disabled citizens. And the cost of this, and I emphasize it's a busy slide, the cost of this in billions of dollars for 1985 was $107.3 billion. That's including lost wages, actual medical expenses, insurance, administration, motor vehicle property damage, and so on. And you'll notice that the motor vehicles constitutes almost 50% of the total cost of what trauma is done to the United States today. How does Oregon stack up against other states around the country? If you look at the rising mortality rates per 100,000 population, green is the lower mortality rates, and the darker the color or the heavier density as you approach red is the higher mortality rates. You can see that the more populated eastern portions of the country have the lowest mortality rates, and the western states and the rural states, such as Alabama and Mississippi, have the highest mortality rates per 100,000 population. Oregon ranks in the bottom 15 in terms of survival from motor vehicle accidents and all types of injuries. There are several ways to reduce mortality from injuries. One is prevention, such as what we've been discussing in the past legislative session with seatbelt laws and motorcycle helmet laws, and the others is improved patient care. The evidence is in from documentation at San Diego County and also in Orange County in Southern California. Putting in a trauma system saves lives. The preventable death rate drops from 70% down to 20%, just from putting in a trauma system. The components of a trauma system, which I won't address in this particular discourse, deals with activation with using 911, selection of trauma patients by triage, communication systems with medical control instead of Medicare control, transportation by ambulance or helicopter, hospital categorization and designation, which is what is concerning us now here in the Portland metropolitan area, how we manage patients, how we evaluate trauma care, how we educate and train our public and our providers to use the system appropriately, and lastly, the quality of research that we can do so we can find out better ways to improve trauma care. The system timeline that we have used began in 1983 when Senate Joint Resolution passed, and this allowed a state trauma plan to be formulated. Based on that plan, Senate Bill 147 was created in July of 1985, creating 10 area trauma advisory boards and a state trauma advisory board to set up minimum standards for trauma care around the state of Oregon. And each area trauma advisory board was responsible for establishing a plan that was submitted to the Oregon State Health Division for approval. Our area trauma advisory board, consisting of representatives from Portland and the 6 surrounding counties, submitted our plan to the Oregon State Health Division in March of 1987. We represent not only Portland metropolitan area, but Multnomah County, Washington County, Clackamas County, and the 3 coastal communities. The big issue that has come to fruition, I guess, or to forthcoming resolution is the trauma regionalization or hospital categorization and designation. We need a limited number of trauma centers to best accomplish our objectives of reducing unnecessary deaths. And the reasons for doing this is as follows. We want to improve trauma patient care by concentrating the cases in a few facilities, which helps the staff to maintain a high level of skill in trauma patient care. Secondly, we want to improve the quality of teaching. By concentrating the patients, it allows sufficient volume of patients for students and trainees in medicine, nursing, and pre-hospital care to learn about the many variations of traumatic injury. Third is research. Clinical and basic science research are enhanced if sufficient volume of patients are concentrated in a few trauma centers, which allows for them to be studied in terms of new technology such as drugs and equipment, alternative forms of treatment, and pathophysiology and other basic sciences that are necessary to reduce the mortality from this injury, from this disease. And lastly, and perhaps just as important, we want it to be cost effective. If too many hospitals duplicate services for trauma with a limited number of patients that are coming into the system and duplicate equipment and have people standing around not being busy, this causes underutilization and increase our costs. The methodology we chose for determining the number of trauma centers in this area was based on basically a mathematical approach. The actual number of major trauma patients injured or killed each year in Area Trauma Advisory Board 1 areas. That would be Portland and 6 surrounding counties. We looked at it from a retrospective analysis and also looking at triage criteria. Now, triage criteria is a way of having simplified methods for identifying major trauma victims in the field so that EMTs can recognize what is a major trauma patient as opposed to a minor trauma patient, so we can separate out those who need specialized care as opposed to those who need routine emergency medical care. Then if we know what that is in the numerator, the total number of patients that need this type of service, then we can put in the denominator how many patients need to be seen at a trauma center, level 1 or level 2, as determined by the American College of Surgeons Committee on Trauma. And once we know these numbers, then we can divide that into the numerator, and that would be the number of trauma centers that are necessary for the Portland metropolitan area. Well, the difficulty is what goes into the numerator. It is estimated that there are probably about 1,000 true major trauma patients that need to have this special type of treatment. However, our triage criteria last year put in over 2,500 patients into the system. Somewhere between these two lies the actual number of patients that need this type of care. The difficulty is in triage is that the descriptions for injury for EMTs is not 100% perfect. It would be nice if it was, but it's not 100% perfect. The ideal triage criteria would select only those patients that need major trauma care and not miss anybody by those descriptions. However, the ideal is impossible to obtain. If your triage criteria are too restrictive, then what happens is that you miss people who should be in the system, and but you have less than a few people who or you don't have too many people entering the system who shouldn't be classified as major trauma. An excessive amount of patients entering into the system would give you no under triage. In other words, you wouldn't miss any patients, but you would have too many coming in, and we estimate there would be 20,000 people injured annually in the Portland Metropolitan area and the 3 coastal communities. Clearly, 1 or 2 hospitals or 3 or 4 hospitals couldn't handle that particular volume either. Ideally, we're looking for a practical solution for the numerator of this equation, 20 to 50% over triage. In other words, some patients are going to enter into the system and don't need to be there because we want to err on the side of safety for the patient, and we're going to miss very few who should be in the system but somehow didn't get recognized in the pre-hospital care field. The next methodology we're willing to look at is where does the majority of trauma occur in the Portland metropolitan area. The majority of trauma occurs in the densest part of the urban area, and if you had to draw a line down the Willamette Valley or down the Willamette River for basically on a couple miles on either side of the Willamette River, starting at the Columbia River, going all the way down maybe to Barber Boulevard, and then out along I-84, you would see where the majority of trauma does occur. Let me go back one. The point I wanted to make is that clearly if you have an area of this particular community, a suburban area where they see relatively little trauma, does it make any sense to put a major trauma hospital there if they're not in an area which serves that particular population? The next methodology we're going to look at is the number of major trauma patients entering into the trauma system simultaneously or within a 1.5 hour time frame. In 1985, we did something significant in Portland. On a voluntary basis, we set up a rule that if a patient had severe injuries as recognized by triage criteria, they would only go to a hospital that had the following resources to take care of them so that the patient would have the chance of getting immediate surgery if necessary. That means in the emergency department there would be a trauma receiving area that was ready and able to take the patient, diagnostic areas such as CAT scanners that were not down for repairs, angiographic suite that did not have a patient there, an operating room that was empty and waiting for a trauma patient as opposed to having somebody already in the operating room, an intensive care unit bed that was available and fully monitored for taking care of patients, and the appropriate human resources such as a surgeon, an anesthesiologist, nurses, emergency department physicians, and neurosurgeons available within 30 minutes. Now, it's important to realize this concept because in 1984, before this system was put in place, you would get 13 patients from the same accident going to one hospital where there was only one emergency physician, no surgeon in-house, maybe an anesthesiologist in-house, and 2 emergency department nurses. Somebody didn't get good care, or quite a few people didn't get good care. So what we did with this voluntary system is that we established a rule: in order to get 1 unit of resources, you had to have those available to get 1 patient. Now then, the way we worked this out was by putting this on a little simplified computer system display, which has a display in every emergency department in town. So, for example, like Emanuel and University Hospital, if they wanted to receive a trauma patient, they had to have all those components that I listed before as green. In other words, they were available. And if any of them were not available, for example, the surgeon was busy, was not in the hospital, was somewhere else, then this would become red, and Emanuel would become red, and therefore the hospital would not get a trauma patient. It would go to a hospital such as the University or to Providence, which was green. And by that simplified system, we were able then to assure, as an interim basis, that the patients who were at least that were getting major injuries were going to a hospital that had the capabilities and the resources to take care of them in a timely manner. We couldn't guarantee that the care was going to be good, but at least the doctors were there and the physical resources were there to take care of the patient. Now then, going back to the issue then, simultaneous trauma systems entries. How many sets of resources that I've just outlined do you need to take care of 97% or 98% of contingencies within the Portland area? Well, we ran the data in 1985, and we looked at the number of incidents that occurred where multiple patients were injured simultaneously that would be entered into the major trauma system. Now, 1 and 2 are way off the scale, but we're looking at people where 3 patients who would qualify for major trauma identification, 4, 5, and 6 would be entered into the system at any one particular point in time. In 1985, we were only able to identify 10 incidences where 4 or more patients were injured within an hour-and-a-half time period. So we reasoned, therefore, that 3 or less groups of resources, 3 or more surgeons, anesthesiologists, sets of CAT scanners need to be available in the city of Portland whether at one hospital, two hospitals, or three hospitals, to take care of our citizens 97% of all contingency cases. Now, the American College of Surgeons has recognized levels of trauma care in terms of commitment. Level 1 is for urban, usually in a teaching center where there is in-house capability. Level 2 in a suburban area where usually the surgeon has and the anesthesiologist are available within 15 minutes with notification. Level 3 is for rural areas where if they can respond within 30 minutes of notification. And we added a level 4 for frontier areas in Oregon, such as out in the southwest or southeast areas of Oregon, where they might not have a surgeon at all, but at least they had some sort of response by emergency physician or family practitioner who would respond in a timely manner to help resuscitate the trauma patient and then help transfer that patient, if they needed further care, to a higher level of care up into the system. The Level 1 Trauma Center is, I emphasize, by American College of Surgeons criteria, is in hospital 24 hours a day, capable of immediate surgery for patients with life-threatening injuries. We chose to go in this particular community with board-certified surgeons, surgeons who had finished their training and who had passed their examinations for knowledge in their particular specialty. Same thing for anesthesiologists, and have an operating room staff in the hospital. Because of the components of suburban areas, we felt that there should not be two levels of care, where a family injured in an automobile accident, one member of the family would go to a Level 1 center where they were capable of immediate surgery, and then another member of the family would go to a Level 2 center where they had to call the surgeon in from home, because then there would be two standards of care within the same community. Obviously, if the one member of the family went to a hospital where the surgeon was 30 minutes on call and the surgeon was late getting in and the patient died as a result of it, there would be two different standards of care and somebody would be left out. So we felt that we would make this in terms of patient care capability. We felt that we would raise the commitment of a Level 2 to equal Level 1 so that every metropolitan patient would have the same level of care and the highest level of care that could be achieved in the Portland Metropolitan area. So that the only major difference between a Level 1 and a Level 2 hospital is in teaching and research in this particular plan. Let's look at costs. This is data that I got from the Oregon Department of Transportation in 1980, and it deals with motor vehicle accidents, and you'll see on the bottom line that $66.6 million were the estimated costs for motor vehicle accidents in 1980 for the whole state of Oregon. But look over here, for severe and critical injuries, which constitutes 3% of the total population, they generated 50% of the total costs. So that's the population that we're looking at to impact in the trauma system, this 3%. Now, some could argue that some of the serious, people with serious injuries in the elderly population and the very young should also be added to this group of severe and critical. And so if you add that, maybe you will come up with about 5 to 6% of the total trauma population that should be entered into a trauma system for dealing with life-threatening injuries. If you realize also that motor vehicle accidents only constitutes about 45% of the total trauma population, that people who are victims of violence, people who are victims of industrial accidents constitute the remainder, then what we're talking about is for trauma hospitals that deal with major trauma, they're only seeing about 7 to 9% of the total trauma population. And the minor trauma will continue to go to the nearest community hospital and receive their care as they always have been, and that constitutes 91 to 93% of the population. So we're not talking about diversion of a tremendous number of patients. We're talking about the high-cost patient who needs high-technology type of care. What does it cost to get this type of care? Well, these are numbers taking the minimum of what we know what some of the hospitals are paying in town for to have a board-certified trauma surgeon in-house 24 hours a day, board-certified anesthesiologist, an ICU physician available, 2 operating room nurses who are dedicated to trauma and doing nothing else, and a CAT scan technician. This amounts to around $3,000 per day, or about $1 million per year for those resources to be available. Now, if you translate that into the number of hospitals interested in becoming trauma centers, you jump from a range of what we estimate of 2 trauma centers and their personnel costs ranging between $2 and $4 million per year, to 5 trauma centers, which is the number of applicants in the Portland Metropolitan area that I'm aware of. That's a cost of $5 to $10 million, and just in personnel costs alone. Remember, these are minimal costs and not perhaps maximal. Now, let's offset that with the charges that major trauma patients can generate. From our data at Emanuel Hospital, the average charge for a major trauma patient who should be in the system is $14,000 of hospital charges per patient. This is not physician's fees, hospital charges per patient. And if the number of major trauma patients is really 1,000 patients per year, then roughly the total charges for major trauma is $14 million. But the reimbursement is not always 100%, as many hospital administrators will be glad to tell you. And the reimbursement is based on patient mix, and it depends upon what type of accidents and injuries that you're seeing. If the hospital is seeing 95% automobile accidents, there's a reasonable chance that 85% of these will be insured. 15% of the people, at least according to our data, that ride the streets of Oregon or highways of Oregon, 15% are uninsured. Motorcycle accidents, only 60% are insured. Victims of violence, about 25%. So your interest as a hospital wanting to become a trauma center is going to be proportional to your patient mix as well as to the percentage of your reimbursement. And the hospital will gain money, depending upon if they see 95% automobile accidents, or lose money depending upon what proportion of victims of violence that they're seeing at their particular institution. So the $14 million I talked about in charges does not necessarily translate into significant income, depending upon the patient that you're seeing. Now, the steps in the process for designation are as follows. The Oregon State Health Division released on June the 29th an RFP, a request for proposal, to all hospitals in the Portland Metropolitan area and the 6 surrounding counties, and they have an opportunity now to submit a proposal to become a trauma center. The Oregon State Health Division will sponsor an applicants conference on July the 15th and to iron out any questions about what is needed to be in this proposal. The deadline for submitting a proposal is August the 28th, so that's 60 days to prepare the proposal. And then on September the 14th through the 30th, a site survey team will come in and visit each hospital, similar to a Joint Commission of Accreditation of Hospitals inspection. On October the 9th, the site survey team will give a report, and on October the 12th, there will be a award of designation status, and probably somewhere around the beginning of November, the trauma system will be implemented for this particular area. The role of the site survey team is to provide on-site review of each hospital applicant, review their medical records and charts to see the quality of patient care and documentation, to observe the hospital operations, how it functions in an emergency, review equipment in the premises, and interview the hospital staff to find out how well they're committed. Now, the site survey team will be appointed by the Oregon State Health Division and will consist of people who are experienced in trauma and trauma systems. There will be a surgeon, a neurosurgeon, an emergency physician, emergency nurse, and a hospital administrator. All these people will come from outside the state of Oregon, and they're to have no conflicts of interest with any members or people within the state of Oregon, so that it can be as fair a process as possible. The cost for these site surveys will be $7,000 apiece for level 1 and level 2 applicants, and $300 for the coastal community hospitals that want to apply for designation. What the request for proposal requires is that the hospital shows that it is committed to providing this level of care. And that must be demonstrated by the board of directors, how well it assigns priority admissions for trauma patients as when they enter the emergency department, what is the budget commitment to the trauma service, what are the qualifications of the trauma team, what are the policies and procedures for the trauma team, do they have a game plan, or is it all chaos when they come down to the emergency department? In other words, it has to work like a pit crew at the Indianapolis 500, and if they stay too long in the pit or too long in shock, they don't survive, and so on. Support from medical and surgical specialists. Can you get the medical and surgical specialists in a timely manner? What quality of teaching and research is done for level 1 applicants? What is the trauma service capacity? In other words, can the hospital take more than one patient simultaneously? And the availability of equipment and personnel in a timely manner. More important to the consumer, which is us, is how well the hospital audits the quality of its trauma care. This is probably the first disease that is going to be publicly discussed in terms of performance, the first disease. And if you want to play in this game, then you're going to have acceptable mortality, morbidity and mortality statistics. Trauma conferences, are they multidisciplinary? Do all the physicians and nurses show up in an effort to improve the quality of trauma care? There's utilization review. Are the beds and the other resources within a hospital adequately utilized, or are they not? Do the nurses audit the quality of nursing care? Again, this is unique to healthcare, and this is, again, I believe, the first disease that has insisted that this be done, and I think it's something that Oregonians should take pride in. Lastly is a major trauma outcome study, which is a voluntary program for trauma centers who will submit their data and compare themselves in terms of performance with other trauma centers from around the country. I emphasize in closing that the quality of trauma care is a consumer's issue, and you should have a very significant interest, because if you're lying at the seat of an accident, you're half unconscious and don't know what's going to happen to you, you're asking society, vis-a-vis the Oregon State Health Division, to make that decision for you, and therefore you're at the mercy of the system, and you want to make sure that the system works. In conclusion, I'm very grateful to the members of the Area Trauma Advisory Board for helping put together this fine plan, and especially grateful to the committee chairman who worked so hard on this. And I would just like to mention and give thanks to Paula Durr from St. Vincent Hospital, to Larry Abbiati, who is a consumer representative from the Heister Corporation. I'd like to also congratulate Dr. John Moorhead from the university, who took care of pre-hospital care and communications, and Joe Acker, who is from the Multnomah County Emergency Medical Services group and in charge of that division. And together, I think that they came up with an excellent plan. Thank you very much.
Thank you, Dr. Long. There will be a microphone set up here in the middle of the room. And as I said at the beginning, if you have written questions now or at some point during this next half hour, raise your hand and Mark or someone will come around and pick them up for you. I'll try to alternate between written questions and oral questions from the floor. You may, depending on the volume of written questions we get, you may have a better chance of getting your question asked and answered if you do line up at the mic in the middle of the floor. Our first question, though, is from our board host, Bill Frank.
Dr. Long, given the competitiveness in the hospital field today, what are going to be the ramifications to the hospitals that are not designated as a trauma center? What's going to happen, and how are they going to handle the trauma patients that they might normally handle?
I think there are several issues on the ramifications. There are political, economic, and patient care issues. The political is almost interwoven with the economic. It has been required by the Oregon State Health Division that those hospitals that do get selected are not allowed to advertise that they are a trauma center. And some of you who have traveled in the Los Angeles area might well see outside some of the hospitals down there big billboards saying level 1, level 2 trauma centers. That we're trying to avoid in the Portland Metropolitan area because I think it will have adverse impact. Secondly is that if there's too many trauma centers that are designated, what usually happens is that there will be a conflict of interest, because then too many trauma centers will have too few patients to take care of. It won't be cost effective. Then in my experience with what happened in San Diego and other places that have tried where they designated too many trauma centers, then they try to manipulate the triage criteria to get more patients coming into the system to offset the costs. This in turn creates a revolt from the non-trauma hospitals, and then the whole system comes down, and then you're back to square one and you don't have any improvement in care. And there's a statewide system that went down for the similar reasons, and that was in the state of Illinois. So that is the political and economic issues. So there's an incentive we think we have built into the process where we keep the triage criteria tight to have as few patients unnecessarily entered into the system as possible in order to get maximum utilization and have a dynamic equilibrium between the non-trauma hospital and the trauma hospital in terms of looking at future triage criteria and deciding that issue and how that's going to be broken out. If you solve that political issue, the economic issue will I think to a large extent, take care of itself. The difficulty in the Portland area, though, also in terms of economics, has to do with the contracting for HMOs and PPOs. And many of our hospitals now or hospital systems are trying to represent themselves as full systems. They can take care of everything from soup to nuts or from transplants to toenails, whichever way it goes. And so consequently, when you're in that kind of a marketing climate, it becomes very difficult to get them to want to back out of a situation where they might not be able to offer full services to the people they're trying to contract with. However, we have built into this process a consumer's issue, which is performance. And the public has a right, I think, through the Oregon State Health Division to say we want to go to the hospital that provides the best quality of trauma care exclusive of the HMOs and PPOs. And that is still to come onto the front burner of public discussion.
Could I have just a quick follow-up?
Sure.
How many hospitals do they plan to designate in the Portland area? Has that been established yet?
We don't know, because until the site survey team comes and tells us whether or not we have level ones here within the community, whether, and how many level 2s we have in the community, the Oregon State Health Division cannot make that decision. We cannot among ourselves make those assumptions until we've had a verification from an outside site survey team. So that's why we've left the process open and yet closed in terms of the limitations of the number of trauma centers that can be designated. Yes, sir.
Bruce Hamilton, member. I'm wondering if we don't already have a central trauma center or #1 trauma center. A year ago, when I was laid out in an ambulance and they started counting my trauma points and they said they were going to call the helicopter, I simply said, I want a manual. And the care I received there was superb. My question for you is, taking the statistics that you have today of the number of patients that are treated in this area, what percentage does each hospital care for?
I can only give you rough numbers because it changes a little bit, but on the average, Emanuel sees between 33 to 34% of the total trauma in this area, followed by University and Portland Adventist running around 20%. Then it would be St. Vincent Hospital running around 13%, and then 8% for Providence Hospital. To my knowledge, there's only 5 applicants for trauma center designation in the Portland area, and those are the hospitals that I just named.
There are a number of other questions here relating to the number of trauma centers to be designated, Doctor, and I wonder if you could say another word or two about that. What is your own prediction about how many there might be designated when this process is done? Is it likely we will wind up with one, or will there be one on each side of the river, or what do you think?
Well, you're asking me to take off my hat as Area Trauma Board Chairman, and now give you speculation as an individual. I think that that the volume here is necessary for only 2 and at the maximum 3 trauma centers if you want to get excellence in trauma care. Now, the geography with helicopters does not become a really big issue. For example, Portland Adventist to the east, if it turns out that they have the best trauma care in the community, people from Washington County can be transferred over there in a helicopter in this, one-third the time that you could get over there by ambulance. So in this particular community, transportation of a patient is not that significant an issue. The issue is I want to focus on is quality of care. Geography does not seem to be an issue. We have talked about the West Hills being a divider. We have talked about the Willamette River being a divider. There, at least in looking at the data that we have seen, there are no geographical boundaries to the movements of patients east or west, north or south, unless you're talking about the Columbia River bridges. But even then, that's not a significant factor until you have peak traffic hours. And every city commonly has peak traffic problems which prevent the movement of patients on ground transport. Now, in terms of weather, the only problems we have when using the helicopters for weather is during the wintertime. But trauma is a seasonal disease. When it's cold and windy and miserable outside, not many people are riding their motorcycles up and down the highways at high speeds and looking forward to the summer weather. Basically, most people are indoors, so the trauma volume falls down during the wintertime and picks up during the summertime. During the summertime, less than 3% of the time, the helicopter cannot fly. During the wintertime, it gets as high as 15 to 17% that the helicopter can't fly. So movement of patients, geography does not seem to be a significant issue. So I get back to the point that wherever the best centers are, I think it's going to come down to 2 or 3.
You mentioned the Columbia River, Doctor. Is Southwest Washington part of this?
They have been part as a subcommittee. We have no jurisdiction in Oregon over Washington, although many people would like to have that. And so consequently, we have asked them to participate with us at the subcommittee level and at the committee level, and to work with us in terms of how they can integrate with the Portland system and the Area Trauma Advisory Board system. So far, we have gotten a lot of interest from Longview down to Vancouver and even out as far west as Ilwaco. And they have been sending representatives, and they are going to work with us in terms of collection of data, movement of patients, and will probably even work with our communication systems. We cannot designate trauma centers in Southwest Washington. We don't have the state authority to do so. The state of Washington is probably 3 to 4 years behind what we're trying to do here in the state of Oregon. But I think we will get cooperation, and so far it seems to be going in a good direction. Yes, ma'am.
Mary Kramer, City Club member. I know that in the area we have 2 nationally prominent physicians in trauma care, yourself and Dr. Trunke. Do you think that just the presence of you two is going to have any influence on the selection process, or will distort any of the objectivity that's been attempted to build in?
And it should not, because I can't take call a 24-hour-a-day trauma call, nor can Dr. Trunke. And consequently, it's the team, it's the institution that's going to be examined, not the individuals managing the team. And so when the site survey team comes through, they're going to be looking for the weakest links in the institutional's commitment, and not for the who's the figurehead for a given institution. And I don't think that Dr. Trunke nor myself will be a significant part of that process, or should not be a significant part of the process. It's the institution and the team's performance that's going to count.
You did not mention Kaiser Permanente. Why not?
Not that I didn't want to. Kaiser Permanente and Good Samaritan hospitals have chosen, for their own economic reasons and future planning, not to get involved with the trauma business, and Kaiser has chosen that they want, at least for their health care plans, that the trauma hospitals that are designated to cooperate with Kaiser, and as soon as the patient is stable and able to be transferred over into the Kaiser system, they will be that will be done. And that is also written into state law. So that cooperation with Kaiser has been done, and they have decided, after looking at all the resources and commitment, that to get involved with the trauma business was not in their best interest.
We have some motorcyclists in the audience, and I have a couple questions from them. First of all, what percentage of trauma patients are from motorcycle-related accidents in Portland? And related to that, were they wearing helmets?
Well, I can't tell you the total percentage because I don't know the data from other hospitals, and we've got, so you'll have to be satisfied with, I can't answer that one part of the question. There is no question that motorcycle helmets save lives. Over 44 states have passed laws mandating that the motorcyclists wear helmets. 22 of those laws have been repealed or have been modified. The mortality each time that has happened has first dropped with motorcycle helmet laws being mandatory, and then risen again as the helmets come back off. In our own data that we've gathered at Emanuel Hospital, the mortality rate for those who do not wear helmets is 10 times those for those who do. It is also interesting that the people who don't wear helmets seemingly don't also buy insurance. So consequently, their freedom to ride the highways without helmets also extends their freedom to ride the highways uninsured, so they don't pay for their health care. And frankly, I would like to be able to reason with people. I think they should have some degree of choice, but if they want to ride without helmets, I think they should pay an increased premium to pay for their health care costs. And so far, we have not been able to get that item on the discussion of the state legislature.
We have a similar question relating to seat belts then. Are there any statistics or projections on the saving of lives or reduction of costs by mandatory seatbelt laws?
Yes, there is ample data showing that the wearing of seat belts, especially with shoulder restraints, do save lives. I can't quote you, figures here, but states that have passed them have had a significant reduction in the number of chest-related mortality as well as head injury-related mortality for wearing it, because people have worn seat belts and harnesses.
Are we all shy today? You can go to the microphone. I'm happy to keep reading these questions, but feel free to approach the microphone if you like. A couple of questions relating to these criteria, Doctor, and what's going to happen later. What parameters exist or will be developed after designation that will guarantee the continued expertise of the designated trauma center?
Someone must have been planted in the audience for that question. That's an excellent question. Built into the process is that there will be an annual review of trauma center performance. So a site survey team will come back and review those that are dealing with it. We have a method in our plan for de-designated trauma centers that cannot maintain just performance, and a process for designated new trauma centers if it is perceived that the ones that have been designated cannot handle the volume that has been projected or that has been entered into the system. So there is a mechanism for dealing with that. And that, again, is information that will be public knowledge, so that, again, we can assure the consumers that they're receiving the highest possible quality trauma care.
Will that be done on any kind of routine, regular basis? Is there going to be a 6-month review for a designation of an additional trauma center, for example?
I'd have to yield to some of this to the state, but as far as looking at the plans that I've seen from the state, it's an annual review, and then after you've had 2 annual reviews, then it becomes a longer period of time before they come back and review data again. And that's the way most states have approached the problem. Some have gone at a 6-month review, and others have gone with an annual review. Yes, sir.
Dr. Long, about 6 months ago, I was sitting here at a city club meeting, eating lunch or trying to, and a waiter inadvertently poured a pot of hot tea all over me. And that was quite traumatic. I got up and ran. Big gobs of skin were falling off, and I got in a cab. Cab driver was not trained in triage, and I selected a hospital. My question is, suppose that happened again today. You didn't bring your black bag with you. What should I have done? What hospital should I have selected?
Well, I think it's not a question of selection. Had you called 911 or called for an ambulance, the ambulance would have selected the hospital for you. Some patients still request the right to select the hospitals where they're going to receive trauma care, especially if they're conscious and oriented. And by and large, some of the ambulances will honor that. But you take the risk of, from the scene of an accident, trying to dictate how the system is going to respond, and the hospital that you may select might be totally occupied with other trauma victims at the time that you arrive, or their equipment might be down for repairs. Again, I go back to 1983 to show you how much things have improved. Every hospital's CAT scanner, if they have only one, goes down for repairs for anywhere from up to 4 to 6 hours, routine maintenance. During that time, before 1985 occurred, patients were still going to hospital with severe head injuries with a CAT scanner that was out of operation. You, as a consumer, at the scene of an accident, dictating where you should go, have no idea what the resources are at the hospital. I would say the best answer is let the EMTs call into the medical resource hospital, who will in turn tell them what is the nearest green hospital that has all the components, and take your chances. Yes, sir.
My question, doctor, is you indicated that, I'm too close, you indicated that the designated trauma centers would be prohibited by law from advertising that fact. What, on the other hand, is to prevent any hospital from declaring itself a trauma center and advertising it?
Well, there's not much. In fact, some would say that they already have done so. But it requires from the state, the official, their imprimatur. If you want that, you're going to have to go through the state process and go through the state methods for determining trauma centers. And what happens is, when trauma centers are designated, with one stroke of the pen, all ambulance traffic changes and helicopter traffic changes within the city of Portland. So if you're not a designated hospital, you can put up a 50-foot flagpole and wave trauma center all you want, but nobody's going to come, and so that doesn't help you very much. Yes, sir.
Jack Brown, member. As a person who lives in Portland and who works in Southwest Washington, I'm perturbed at the idea that Washington's 4 or 5 years behind Oregon in this process. If this is a consumer's issue, how do you suggest that those of us who are consumers get Washington up to speed and get you folks to cooperate with the state across the river?
It's a difficult thing to build consensus to what needs to be done. And many of you were aware with the Northwest Oregon Council of Hospitals' efforts to build a trauma system back in the early 1980s. And there was a lot of work done in that area, and I know that one of the administrators here in the audience, John Grotting, spent innumerable hours chairing committees to try to get some sort of consensus of what to do with trauma systems. It requires a broad spectrum of people involved: consumers, EMTs, nurses, physicians, hospital administrators, sitting down and looking generically at what the problem is and recognizing that there is a problem. In many parts of Washington, just like when we started in many parts of Oregon, there was no problem. Everything is hunky-dory. Everything is great. There's no need to deal with this particular issue. But you bring in the facts. and you get the facts that are readily available out of the public health offices, you can get them out of the Oregon Department of Transportation, and you point out that there is unnecessary mortality. And we started basically in this state 3 years ago with showing data that came out of the Oregon Department of Transportation and from Susan Baker's book showing that Oregon ranked in the lowest 15 in the country, and there was a problem with rural health care, and there was a problem with suburban health care, and there was a problem with urban trauma care. Dan Lowe's study from the University of Oregon also was a major impetus to show that the quality of care was not all that great. And then we had outside experts come in and point out that they in their own state had problems going through the same process. And when you get that kind of consensus beginning to build that there is a problem, everybody agrees that there's a problem, then you can start formulating decisions. Washington has not gone through that yet. They have not had a statewide consensus on this issue. They have had some impetus from Seattle, where the University of Washington taking the lead, but outside of Seattle, not too much has been done. And you have to get Spokane, Yakima, and all the other significant cities in the state of Washington to come and sit down at the conference table and begin to think about this particular issue and realize that they have to do something. And until that happens, it won't happen.
With respect to the measurement of quality of care, Doctor, can you say anything more about the indicia for measuring the quality of care? And can you, or do you have any comparative data on survival statistics between your team and other area trauma teams?
Well, that was an issue that we discussed long and hard at Area Trauma Advisory Board. The Major Trauma Outcome Study was funded by the Robert Wood Johnson Foundation and then by the American College of Surgeons Committee on Trauma. And the Major Trauma Outcome Study basically measures two things. It measures the physiological state of the patient, in other words, in terms of blood pressure, respirations, and conscious level at the scene of an accident, and then it measures the amount of injuries that are by organ system or by body areas that are at the time of discharge. And you compare those and you can get a point on a graph as to how severely injured the patient was physiologically and anatomically. You can then compare that population with, from one trauma center with another population center and look at the amount of people who live and those that die. Clearly, the ones that have the higher proportion of lives in the upper right portion of this graph that I'm drawing are getting successful stories in places where the people would normally have predicted a higher mortality rate. If you have deaths where people, in areas where you shouldn't have deaths, down to where they're physiological stable when they come in, they have relatively minor injuries, then your performance is not very good. The Major Trauma Outcome Study has analyzed the data now from around 113 different trauma centers around the country. They have collected data on over 80,000 patients now. And what they have come up with is a standard mean of trauma care based on severity of injury that I just described. If your hospital performance or standard of care is above that line, you are doing very well. If you're below that line, you're doing very poorly. And statistically, if you're 2 standard deviations above that line, you're doing exceptionally well. The range of trauma care in this country, for those who have voluntarily decided to participate in this, ranges from +4 standard deviations above the national norm to 8 standard deviations below. I'd like to know where the one that's 8 standard deviations below, because I don't want to go near that state. But only the hospitals submit this information voluntarily. The information is coded, and unless the hospital is willing to release that information to the public at large, that information will never get known. So I can, bring out what's happening at my own particular hospital in terms of that standard, but it would require the cooperation of other hospitals in the area applying for trauma center designation to release the same amount of information for it to be meaningful. And so I don't know what the others have done, so therefore that's why I haven't made too much of an issue. We tried to get that through the Area Trauma Advisory Board, but we felt that it was too controversial an issue, and maybe it's something we can bring up at a future point.
My name is Phil Bogue, member of the club. I've been reading some stories lately about the safety record of life flight helicopters, and I sort of have decided that if I find myself in the need of the services of a trauma center, that perhaps, and I'm still conscious, Lord willing, I would demand the services of an ambulance rather than a life flight helicopter. Is this a problem, and if so, what's being done about it?
It's a national problem because so many hospitals have tried to get into the trauma and emergency medical services business by contracting with fly-by-night helicopter companies that run a low-budget operation and it's high risk. And so consequently, the helicopters are going down across the country. Life Flight began as the fourth oldest civilian helicopter system in the country and has one of the best safety records in the country. And I think it's important to realize that it's something that Oregonians should be proud of. It is now a community resource. It began with Emanuel Hospital. Now then, all the other hospitals, or most of the other hospitals in the city of Portland, have a stake in the management of Life Flight and also its operating costs. And it runs a very, very highly successful program. And the safety record has been acknowledged by an award from the people called Ashbeams, who recognize who are part of this emergency medical helicopter system. Yes, it is a national problem. It's a major concern for safety, and now the federal government is moving into this area to establish a higher regulation of EMS helicopters, and so, rightly so.
HMOs are a growing phenomenon, Doctor. How will reimbursement to a non-participating hospital caring for an HMO trauma patient be handled? Will it be mandated?
I can't answer that. I don't know how the contracts are going to be until we have found out who the trauma centers are going to be, and then the HMOs approach the trauma centers and ask if there's a contract that can be arranged in terms of their costs. Right now, at least for Kaiser, to my knowledge, Kaiser has been paying whatever the charges have been for trauma care that goes to non-Kaiser hospitals, and maybe other HMOs will follow that. Maybe they won't. I don't know. That's something that has to be worked out in the future between institutions and HMOs and PPOs.
A question about children. Are there any special aspects of what you've told us, Doctor, that relate to kids in Oregon?
There must be a pediatrician in the audience somewhere. We are, at the moment, dealing with a grant that was received from the Human Health Services Maternal Child Health Division for looking at pediatric critical care and trauma in the state of Oregon. Not many of you, or some of you may know that this grant was competed for by about 30 to 40 different states around the country. And Oregon, I believe, was the only West Coast state to get one. There's only 4 that was granted, and we got one of the 4. We are in the process now of developing a pediatric critical care system for around the state, recognizing those hospitals that have emergency department capability for managing pediatric patients, and those hospitals that have tertiary care for managing all the problems with kids on ventilators, with head injuries, and so on. We have focused to a great degree on the management of pediatric head injuries because that constitutes a significant proportion of all the types of injuries that a child would have. We hope to have by next spring a defined pediatric system for critical care and trauma in place. And we will attach that to the existing adult trauma system that we're building right now. And we chose to uncouple pediatric trauma from adult trauma because of the pediatric issues were still fairly undefined when we got started, and it's simpler to deal with the adult first and then put the pediatrics on top of it. But yes, there is a process in place, and we're moving in that direction.
Our last question, Doctor, a little change of pace. Emergency room doctors in southern Florida are on strike, blaming the high cost of malpractice insurance. Could we have your comments?
Well, it's not only emergency department doctors, it's neurosurgeons and anesthesiologists are also on strike. And part of this is all intimately related with tort reform as well as it is for malpractice costs. And many of them are on strike not because of the trauma system. The trauma system has merely catalyzed or precipitated this particular crisis. In Miami especially, there are many south of the border people who are living in Miami either legally or illegally. Many of them are not involved with any sort of health care insurance, and so the cost of providing trauma care and any type of emergency medical care is phenomenal. In addition, there is the malpractice costs in Florida, which runs somewhere around $200,000 for malpractice for a neurosurgeon and about $175,000 a year for a general surgeon, or so on. These are high costs, and so when they are treating a large number of patients who are not compensated, who in turn are who are suing them for poor quality of care, this leads to a lot of unhappiness. And so consequently, there has been no incentive for tort reform, or very little incentive for tort reform in Florida, and so some of the key players are beginning to drop out. And we have talked about trying to prevent this from happening here in Oregon, and there's several plans afoot to hopefully that will minimize this from happening here.
Well, thank you very much, Dr. Long, for being with us today. Again, I'd like to encourage our guests who are with us today to join the club. You have membership cards on the table, and encourage our members to invite someone to join. We're adjourned till next Friday.